Hello everyone. Let me first introduce myself. I am Dr. Pallavi Kalgadgi and I work at Xenith Advanced Fertility Center. As a part of the Xenith support activity, today we will be talking about endometriosis and infertility. I think the concept of endometriosis and its association to infertility is an enigma to everyone going through it. So to make this topic more relatable to our patients, we have decided to go about this session in a Q&A structure. And to answer our questions, we have our director and chief IVF consultant at Xenith Advanced Fertility Center, Dr. Mamta Dighe. We have tried to include most of the elements related to this topic, but if anyone has any further queries, you can write to us at info@zenith.clinic. And for further updates on our upcoming videos and posts, please like and follow us on Instagram and Facebook and subscribe to our YouTube channel. Now, let me invite to this meeting Dr. Mamta Dighe.
Hello, Pallavi. Thank you.
Dr. Mamta, how are you?
I'm good. How are you doing?
Ma'am, today we are going to be talking about endometriosis and infertility. So
Yes.
we'll do it like a question and answer round so it becomes more understandable to our patients.
Sure.
Okay. So should I start?
Yes, please. Let's move.
Okay. So the very first basic question is, what is endometriosis? Like just the definition and general explanation about it.
Okay, so what I'm going to do is talk in a very layman's language so that our audience gets a real understanding of what endometriosis is, especially because so much is found over Google. I want to have this in an explanatory manner. So basically what happens is we have the uterus, and the uterus has a muscular layer, and the lining or the cavity of the uterus is lined by special cells, which is called the endometrium. Now, the muscular layer is separate and the endometrium is separate, and there is a very fine distinction between the endometrium and the myometrium or the muscle layer. When the endometrial cells of the uterus start invading into the muscle layer of the uterus, or when these cells, the endometrium, that is the inner lining of the uterus, the cavity where the baby is growing, these cells start, getting outside of the uterus. These cells are not supposed to be outside of the uterus. When these cells start spilling outside the uterus, maybe onto the ovaries, in the pelvis, on the tubes, and in many other different areas, then this condition is called as endometriosis.
Okay, ma'am. So then comes the next question, that why does this uterine tissue get to where it does not belong? And how does it happen and why does it happen, basically?
I think that despite all the advances, endometriosis, like many other things in science and biology today, is still an enigma. In fact, I don't remember the poem, but there used to be a very lovely poem, on how endometriosis is an enigma. So there are theories, okay? We do not really know exactly why this happens, but the most commonly accepted theory is that the cells or the lining of the uterus, which is shed during the menstrual cycle and comes out in the form of menses, is supposed to flow out of the uterus through the cervix out into the vagina, which we see as menstrual blood. Now, while this is happening, what happens is that these cells also have a backflow, because we have the two fallopian tubes which are attached to the uterus, and the fallopian tubes open into the pelvis, and on the inner side they open into the endometrium, so into the uterine cavity. So what happens is that these cells backflow from the tubes into the pelvis, and that is how the menstrual blood or the lining or the endometrial tissue gets into the pelvic area, and from there it spills onto different parts of the pelvis. Now the question is that why does it happen only in some women? Or the question also is that even despite some women actually having this backflow, they actually clear off these cells from their body. So basically, these cells get cleared off, even if there is a spill. Most of the times, there is no spill, but even if there is a spill, these cells get cleared off. But in women who suffer from endometriosis, they have this backflow, and the cells also do not get cleared off from the pelvis, and they continue being there. And with each menstrual cycle, you have more and more of this spillage into the pelvic area, and the endometriosis keeps growing. So this is the commonest accepted theory. The second is immunological, like I said, that some people will kind of clear off these cells, but the immunity of some women will not allow these cells to be cleared off. There's also a theory which believes that the lining of each lining, like suppose if you, the common example I give my patients is, if you look at your cheek, the inner part, has a different layer, and, your cheek and the skin has a different layer. So if that inner pinkish mucosal area starts invading, the external part, you're not going to be able to have a clear demarcation, and you're not going to be able to chew your food, taste it, because everything will get mixed up. So each lining is separate, and sometimes it is also believed that these lining, which is in the pelvis, sometimes changes itself and becomes like an endometrial tissue. So there are many theories, but the commonest is accepted is the one where, we think that there is a backflow from the tubes into the pelvis.
Okay. Okay. The next question, ma'am, is why would one suspect that they have endometriosis? So what would the symptoms be like? What would be the common complaints they come with?
The three commonest complaints, or it's called the triad, is pain, infertility, and painful intercourse. So if a woman has these three symptoms, the most commonest ones, which is pain, especially severe dysmenorrhea, that means severe pain which is refractory to medication. So despite taking medicines or having too much of medicines, if there is severe dysmenorrhea, if they are suffering from infertility, and if they have painful intercourse, especially deep dyspareunia, then these are the three main commonest symptoms of endometriosis. Having said that, sometimes endometriosis will have no symptoms at all, and a woman will not know that she has endometriosis unless she comes to a gynecologist for some reason, and we happen to get it as an incidental finding on examination or sonography.
Okay. And once now, the main important question is that why is endometriosis causing infertility? I mean, that is our main question at this point of time, that why are we having infertility in such a case? What is exactly happening in the body?
So again, like like why endometriosis happens, there are theories. We know that some of the reasons why endometriosis causes infertility, and there are some other theories as well, linking endometriosis with infertility. So the commonest thing that happens is that endometriosis starts invading the ovarian tissue. Most of the times, this blood, or the endometrial tissue, will start implanting on the ovaries. And once they start invading into the ovaries, the blood will start getting collected over there. It will become a cystic mass, which we call an endometriotic cyst. And this endometriotic cyst will take up the ovarian tissue. So whatever ovarian tissue and the eggs are there, or the oocytes are there in the ovary, basically it will start getting replaced by the blood and the endometriotic tissue. So it is affecting the quantity and the quality of the eggs in the woman. The second thing is, because there is blood spillage into the into the pelvic cavity, what happens is that there is a lot of adhesions. All the organs start getting stuck up, adherent to each other, stuck to each other, because of this bleeding that keeps happening again and again over a period of time. And because everything gets into a clumped mass, The tubes will not be able to move properly. The pickup of the egg from the ovary will not happen properly. So everything kind of comes together and becomes like a clumped mass. That is the second reason. Third is this tissue has toxic material which is toxic for the eggs and the sperms or the embryos. So because of this, again, it will cause infertility. And there are many, many more theories, but suffice to say that endometriosis can drastically bring down the fertility potential of the woman. So the fertility chance that she has, pregnancy chance that she has, is brought down quite to a large extent because of the presence of endometriosis. And these are some of the reasons or the causes behind it.
Okay. Thank you, ma'am. That was really nice, elaborate, and vital information. So that said, can a woman conceive naturally then if she is having some amount of endometriosis? Would she be able to even conceive naturally?
Yes, definitely a woman can conceive naturally even with endometriosis. In fact, sometimes we have found endometriosis as an incidental finding. When you're trying to do a tubal ligation after 2 deliveries, when a woman wants to clip her tubes or have a tubectomy, and when we are planning to do that procedure, then we end up seeing that there is endometriosis. But it depends on the severity of the endometriosis. So endometriosis is graded as minimal, mild, moderate, and severe. So if you have the lower grade of endometriosis, a minimal or mild, usually these are the conditions under which there are greater chances for the woman to conceive naturally. But if the endometriosis is moderate to severe in nature, then sometimes, yes, it becomes difficult for the woman to conceive naturally.
Okay. Okay, ma'am. So say that we have concluded, diagnosed that the woman is infertile, and we have a moderate or a severe grade of endometriosis. So now what would be the treatment options, or what would be our approach towards these patients?
So basically, the commonest way endometriosis is diagnosed is based on symptoms. Even having premenstrual spotting, women who give a history of a continuous premenstrual spotting, again, we should become aware and suspicious that we need to rule out endometriosis in these women. So the most common way is if they come for pain or for infertility to the gynecologist, and either an examination or an ultrasound will show that there is evidence of endometriotic cysts, or you will see that the ovaries are very adherent, or if you have decided to do a laparoscopy. So a laparoscopy is a keyhole surgery. So we take a small incision below the navel and put a camera inside, and that is the gold standard for diagnosing endometriosis. So once we have diagnosed endometriosis and decided on what is the grade of endometriosis, if it is a minimal to mild grade of endometriosis, if it is a younger woman, she has a good ovarian reserve. By that, I mean that she has good number of oocytes in her ovary. There are no other additional factors of infertility, and the tubes are good and patent. Then in such women, if we have done a laparoscopy, we kind of correct, it's called ablation or cauterizing the endometriotic spots or removing the endometriotic cyst. And then we subject these patients to ovarian stimulation followed by an intrauterine insemination. So there are many studies which have shown that instead of tying naturally, if you do an ovarian stimulation followed by an IUI in these couples, the conception rate is far better. So that would be, the kind of treatment we advise. But again, There is no, I think we are in the era of individualization. We can't put everybody in the same basket. So we have to look at the individual characteristics. We have to individualize the patient. We also have to look into the grade of severity of endometriosis and then go ahead and plan the treatment. But just to give an overview, I think for endometriosis, it is either doing a laparoscopy and correcting the endometriosis, followed by an ovarian stimulation and a controlled and an intrauterine insemination. And if it is a severe grade of endometriosis, we even have to resort to IVF in such patients.
Okay. So then you would say that every woman who has got endometriosis wouldn't really need a laparoscopic surgery, right? So
Yes, you're right. Now, one is it's not necessary that the moment you suspect endometriosis, you have to do a laparoscopic surgery. Because if the tubes are patent, she's a young woman, she has got good number of oocytes and a good ovarian reserve. The other male factor, the semen count is completely normal, then this woman can either conceive naturally, or even if you attempt to do an intrauterine insemination with an ovarian stimulation before the laparoscopy, that could also give her a chance of success. So it is not mandatory or necessary that every woman has to immediately go through the laparoscopic procedure.
then that said, ma'am, when you do an IVF, or when you have to deal with infertility with the endometriosis patients, what are your biggest challenges that you face during your treatment?
I think the biggest challenge is the number and the quality of the eggs, because that is exactly what happens in IVF. Is basically we are in any case bypassing the fallopian tubes. So, even if there are adhesions in the pelvis, etc., we're not so worried. Of course, adhesions can affect a little bit to ovarian stimulation, but basically we are bypassing those things, so we are not so worried. The most important thing is getting good embryos, and those embryos being able to implant into the uterus. So the biggest challenge is getting good numbers and good quality of eggs so that we can form good embryos. And the second challenge is many times women who have endometriosis also have the endometriosis in the uterus, which is called adenomyosis. So in such cases, when you put the embryos back into the uterus, for women who have adenomyosis, it can decrease the chance of these embryos sticking to the lining of the uterus. So these are the two biggest challenges that we face when we plan an IVF in women who have endometriosis.
Okay. So when you say that this the challenges that you face, so is this cycle, like the treatment that you do for endometriosis, the IVF treatment, is it different from a normal IVF treatment where a patient does not have endometriosis? So is there approach towards that in IVF? I mean specifically for IVF, would it be different? Would it be a different cycle altogether?
I think yes, it definitely would be. In fact, I think that the problem is that many times patients ask me, like, what will you do different, and I tell them it's very difficult for you to understand what I'm going to do differently, because for the patient it is just taking injections and going through the retrieval and putting the embryos inside. But a lot of things change when the doctor individualizes the stimulation protocol and decides the kind of protocol, the kind of drugs, like what you're going to do, when you're going to put in the embryos, are you going to freeze them, what will you do before putting them inside. So all these things matter, not just for endometriosis, frankly, for every patient, because each patient needs to be individualized. But having said that, yes, when you are, treating a patient who has endometriosis and they need to go through an IVF, there are different protocols which help to improve the quality and the quantity of the oocytes that we retrieve from such patients. So we definitely have different protocols for patients who are going through ovarian stimulation for endometriosis in IVF, and even for women who are going through a frozen embryo transfer, if they have adenomyosis or endometriosis. Again, there is a different protocol wherein we suppress the endometriosis or adenomyosis and then try and implant the embryos back inside. Also, having an excellent IVF lab, having very, very good embryologists, having an excellent IVF lab is key, because what happens, since the quality and quantity of oocytes is reduced, the number and the grade of embryo that we can get starts getting affected. So having impeccable lab conditions and experienced embryologists is key to giving pregnancy for women who have endometriosis.
Okay. I think that was a very nice and a detailed explanation, ma'am. My final question. So there are a few patients who keep asking that, we have endometriosis, we are getting treated for IVF, but now that we are taking these fertility medications, these injections, is our condition of endometriosis going to get worse? Is it going to be worse after they are done with the whole treatment? So what do you say
I
about
know
that?
this is a very common question, and I think it's very important to address that it has been shown that ovarian stimulation is not really going to worsen the endometriosis. So, when you do the stimulation in the right manner, it is not that just by causing the ovarian stimulation, you're going to end up increasing the endometriosis. There are enough studies to show that that does not happen. What we need to be careful about is when you're doing the oocyte retrieval, you need to avoid going through the endometrioma, not only so that you do not disturb the endometrioma, but also so that, you do not pick up the oocytes with some of the endometriotic fluid and tissue that comes when you go through the endometriotic cyst in the ovary. So it needs a lot of technical expertise to make sure that you do the oocyte retrieval properly. But if the ovarian stimulation is done in the right manner, then doing ovarian stimulation for IVF is not necessarily going to increase the endometriosis.
I think that is about it from my side. Is there anything else that you would like to say? Anything that you think is a...
No, there's one probably thing that I'd like to say is, endometriosis in girls and women who are not married. So what happens is that, of course, we've discussed, because we are basically a fertility clinic, we address and we see most of our patients who come for reproductive issues, who come for, endometriosis having affected their ability to bear a child. But there are a lot of girls and women out there who are sometimes not yet married. There are some young girls, and there is a lot of endometriosis that they are struggling with, and it's a very difficult thing for them also to handle, because it keeps causing pain. Marriage and childbearing is not on the horizon immediately, so tackling such patients is again a very, very, you need to approach them with a lot of care and sensitivity, and again individualize the treatment for them. And that is something I think women or girls who, if you all are having very, very bad severe dysmenorrhea over and over again, see, we are not trying to say that if you have little bit of pain during your menses, rush to a gynec. Please do not, because every woman will have some pain during her menses. But if there is severe dysmenorrhea over many years or many, many months, if the dysmenorrhea gives rise to, vomiting, it is, you are unable to go about your daily activities, if you know that, you start spotting before your menses, and then you start a proper flow, and this happens on a regular basis, then such women should probably, meet the gynecologist to make sure that they are not dealing with endometriosis. And again, definitely somebody who has been trying for more than a year to have a baby and have yet been unable to have one should again meet their gynecologist, because the incidence of endometriosis in people who have infertility is much, much higher than in women who do not have infertility. Like I said, it's one of the three, main, the triad of endometriosis. So probably this is one more thing, for just everybody to become aware.
Yeah, definitely. That is also very much needed. Awareness of, what we are going through is what is very important. I think, ma'am, that's about it. If anybody has questions other than what we have asked, and if you all have any queries, please write to us. We can probably, you can probably have check our website. We have the link for the Instagram, YouTube, as well as the Facebook link, and you all can write to us there. And I think that's it.
Thank you,
Thank
Pallavi.
you
And
so
I
much.
think I must thank you, because I know that, you discussed with me that, ma'am, I want to do this and create awareness because a lot of patients keep asking. So let us do this. So thank you. And we really want to make sure that we try and create more and more awareness. I think we are in the, the age, the information age or the digital age, and no person should have a problem because of lack of information. That is, that is something that we are able to get today just sitting at home. So I think that is something that we are working on, try to create more and more awareness, because when you're informed, then you can take a very, very good and an informed decision. So thank
Yes,
you.
and I also think there is too much information in some places, so we don't know if it's right or wrong. So as infertility specialists, I think we definitely would be able to give out, the most accurate information. So I think that everybody should, have all of this data available. So let's see how that works. And thank you so much, ma'am. Today was really nice.
Thank you, Pallavi. Thank you so much. Yeah, and we'll keep doing more of these.
Definitely, yeah.
All right.
Okay.
All right. Okay. Thank you. Bye-bye, everybody.
Bye.
And like Pallavi said, that please continue following us. We'll make sure that, we keep creating good content so that you have answers to almost all questions that you may ever have. Thank you so much. Bye-bye.